Welcome, everyone. Thank you all for joining us today. I'm Michelle Jester, the Research Manager at the National Association of Community Health Centers and the Manager of the PRAPARE project. And I'm very excited to be here with our PRAPARE co-principal investigator, Rosie Chang-Weir, who is the Director of Research at the Association of Asian Pacific Community Health Organizations. We're really excited to be able to talk to you guys and present some findings from our PRAPARE pilots that really highlight the impact that social determinants of health have on health outcomes. Now, at any time during this webinar, if you have a question, just given the number of people on this webinar, please put them in either the Q&A in the chat box, and we will get to as many questions as possible at the end. So most of you are likely familiar with PRAPARE, but just as a very quick reminder, PRAPARE is a national standardized patient risk assessment protocol that allows organizations to collect patient-level data on the social determinants of health that they face. And we really hope that organizations can use this to not only better understand their patients and the circumstances in which their patients live and use that to inform patient care, but we really also hope that you can use this data at a more organizational planning level to figure out what other different types of staff do you need to address social determinants? What other community partnerships might you need? What other services could you be providing to really help address these non-clinical root barriers to poor health? And then we also hope that you can really act on it and use it for community transformation purposes to really inform different payment models and other different types of delivery system transformation. So you can find the PRAPARE tool at our website at nac.org/prapare, which is on the screen, and you can find lots of helpful resources as well. And just as a reminder, this was a very large partner initiative between us at the National Association of Community Health Centers, along with our partners at the Association of Asian Pacific Community Health Organizations and the Oregon Primary Care Association. So over the past couple of years, we have been working with multiple health centers and health center controlled networks and other stakeholders to develop the PRAPARE tool, build it into multiple electronic health records, test it in different clinic workflows and figure out what works best, and then packaging all of those implementation best practices and lessons learned into our free PRAPARE Implementation and Action Toolkit. And this is all thanks to generous funding from our foundation partners, including the Kresge Foundation, Blue Shield of California, Kaiser, and some Texas state-based health foundations as well. Here are the list of the PRAPARE EHR templates that are currently available. So we currently have them for NextGen, eClinicalWorks, GE Centricity, Epic, Cerner, and Greenway Entergy, which you can access at our website. And we're also working to develop some EHR templates for Greenway Success EHS, Allscripts, and Athena. And here's just an outline of the PRAPARE Implementation and Action Toolkit that, again, we didn't want organizations to simply just collect data on the social determinants. We really hope that you can act on it. And so we tried to package everything that we had been learning from our users on the ground as to what steps you really need to take to successfully implement PRAPARE and then really act and use the data. So for the past couple of years, we have been working to spread PRAPARE and train others on really how to implement it in the clinical setting and use it for transformation purposes. And we're now working with about half of the states to spread PRAPARE, but we have done focused pilots in the following states, which are highlighted in orange. So those include Oregon, California, Texas, Iowa, New York, and Hawaii. And these are the states in which we have aggregated PRAPARE data from 17 health centers to do some evaluation work to highlight social determinants' impact on health outcomes. And with that, I'd like to turn it over to my colleague, Rosie Chang-Weir, who has been leading our PRAPARE evaluation work to talk more about the methodology and our findings.
Thank you so much, Michelle. I just want to confirm you can hear me?
Yep, sure can.
Perfect, perfect. Thank you so much, Michelle. We're really excited to share with you in our presentation today some of those findings that we've been working on with these PRAPARE pilot sites, as well as some plans to conduct additional analyses to look more closely at our outcome data under a recently awarded grant with our health center partner, as well as partners from the University of Chicago. So I want to first start with our findings using PRAPARE data comparing high-risk versus general populations of focus. And then we'll follow briefly by a separate study findings looking at hypertension, as well as a study among patients with controlled versus uncontrolled diabetes. I wanted to be able to cover all of these, and so won't have too much time to go into detail on all of them, but we're in the process of writing these up, and of course, you can feel free to ask any questions at the conclusion of this presentation as well. So let me advance the slides here. Okay, great. So in the first analysis that I'll share, we compared high-risk versus general populations of focus from a national sample of health centers located in California, Hawaii, Iowa, New York, Oregon, and Texas. We've really been fortunate to work with every single one of these sites and with health center controlled networks to be able to learn so much about the data collection implementation process. So we're really grateful to have the opportunity to work with them and share some of these findings with you. So for the purpose of this analysis, we categorize the populations into either a high-risk population or general populations based on the populations of focus that the health centers implemented PRAPARE. So for example, high-risk populations were those patients with multiple comorbidities, seeing a chronic care management team, or patients with HIV or mental health diagnoses, whereas implementation with the general populations included all patient populations without distinction of a particular or specific populations of focus. So in total, we had about 7,000 patients in this analysis, with closer to 3,000 patients in the high-risk group and 4,000 in the general population group. In our analysis, in addition to looking at general descriptives and frequencies of all the PRAPARE domains, we also developed a PRAPARE Social Determinants of Health Total Score to better understand the extent of patient risks and complexity across all the PRAPARE domains. So this Social Determinants of Health Total Score represents the cumulative number of distinct risks that are present versus absent for an individual patient. So this score is like a Social Determinants of Health tally score that's calculated by summing the total number of present social determinants of health risk responses as defined by literature for an individual patient completing the full PRAPARE assessment that includes 22 domains. So just to give you an example, for the domain of housing status, risk is defined as not having housing, whereas the absence of risk would be defined as having housing. Similarly, to give you another example, high school or lower education is considered a risk, whereas more than high school education is not. So we developed these across the PRAPARE domains and use this as a basis for developing the Social Determinants of Health Total Score. We also conducted t-tests to identify differences in PRAPARE Social Determinants of Health domains between the two groups, the high-risk and the general population group, using a p-value of 0.05 from which to assess differences. Okay, so in the, I want to go into the results of this. In the graphs I'll be presenting, note that for the most part, we tried to use the red color in the graph to indicate the social determinant that is considered the greatest risk according to the literature. So in this graph, it illustrates the social determinants of health total scores, which again is the total number of social determinants of health risks for an individual patient based on full PRAPARE data collection. So the lines are shown for the high-risk group in red versus the general population group in purple. And so the lines here thus represent the percent of patients with the social determinants of health total score indicated on the x-axis. So as you can see in this graph, for the high-risk population, the mean social determinants of health total score was about 10, which was nearly twice the number of the social determinants of health total risks for the general population. So that what this means is that high-risk populations, such as those facing multiple chronic conditions, on average, also face about double the number of social determinants of health risks. To give another example, this means that these high-risk patients have 10 simultaneous risks, which could be any combination based on the PRAPARE assessment, such as limited English proficient, low education, lack of housing, unemployment, transportation, and 5 others, all 10 at the same time. So whereas in the general population of health centers, they tended to have an average of 5 of these total social determinants of health risks. So, this implies and is consistent with the growing literature about the impact of social factors as fundamental correlates of health and disease, especially for underserved, high-risk patients served at community health centers. When we compared the high-risk and general population groups on the distribution of domains, we also found a lot of significant differences shown in this table based on the t-test using known responses. So, for example, the high-risk group had significantly more patients with lower education, more low-income patients and patients on Medicaid, more Hispanic or Latino patients, as well as more Asians, more Native Hawaiians, and Pacific Islanders. The high-risk group also tended to have more patients with limited English proficiency, more patients needing transportation for both medical and non-medical reasons, more that are unemployed, and more patients worrying about losing housing, as well as with higher child care needs. And so I'll go over these in a bit more detail in these following slides. So I wanted to share some of the results for these domains, just to share with you some of what the distribution of responses looks like. So here's the response for race and ethnicity. As you can see, the high-risk group had a higher number of communities of color, such as Hispanic, Latino, Asian, Native Hawaiian, whereas the general population contained a higher number of the white population. Similarly, when we look at limited English proficiency, or LEP, there is a higher proportion of those speaking a language other than English in the high-risk group. And this is consistent with literature indicating that patients with limited English proficiency have higher social complexities, which may have to do with challenges in navigating the health or social system, especially when you can't appropriately communicate your needs, both health and social needs. In terms of health insurance, we see a much higher proportion of the high-risk patients on Medicaid at 52% versus 27% for the general population, as shown here in blue. We also see a similar pattern with income here, with high-risk patients who have a larger proportion of patients in poverty, 100% federal poverty level, compared to the general population, shown here in red as well. When we look at the question about transportation, basically asked whether lack of transportation kept patients from medical appointments, meetings, work, or from getting things needed for daily living, we see a larger proportion of these transportation needs for high-risk patients compared to the general population of patients, as shown in the red bar here as well, 20% versus 13%. And also, in terms of worry about losing housing, we also see here that more high-risk patients also worried about losing housing compared to those in the general population. In terms of employment, high-risk patients had a higher proportion of those that were unemployed, as well as a lower proportion of those that had full-time work, 14% versus 25% is shown here in the green bars. So overall, in terms of the common social determinant risks, we're seeing limited English proficiency, less than high school education, uninsurance, experiencing high to medium stress and unemployment as some of the more common social determinant risks. In terms of assets, it was interesting to find that social integration was actually an asset. Greater than 50% of patients see those that they care about 5 or more times a week. So let me now go into, I wanted to briefly share another analysis that we did with our first cohort of PRAPARE implementers with a total of 7 health centers nationally, looking at the relationship between the number of social determinant risks, or again, social determinants of health total score correlated with hypertension. So we did this correlation analysis between the percent of social determinants of health risks and percent of patients having hypertension, and found a moderately strong relationship. So what this means is that the number of simultaneous, as the number of simultaneous social determinants of health risks go up for patients, so does the likelihood of patients having hypertension. So I wanted to briefly share that analysis with you. And then now I wanted to go into the analysis in which we looked at diabetes, particularly patients with controlled versus uncontrolled diabetes. So we conducted this other study using logistic model analyses to assess how much more likely it is for a patient to have controlled diabetes versus uncontrolled diabetes when the patient has certain social determinants of health barriers holding all of their factors constant. So this sample included patients diagnosed with diabetes who were screened using PRAPARE during a 1-year period. And after cleaning the data, the final sample included about 1,200 patients with close to 1,000 controlled diabetics and a little over 200 uncontrolled diabetics. In addition to the logistic regression analysis, we conducted t-tests to compare social determinants of health risks for those with controlled versus uncontrolled diabetes. So here are the results from the t-tests, again, comparing whether the controlled and uncontrolled diabetics were significantly different from each other. These results from the t-test indicated that compared to controlled diabetics, uncontrolled diabetics had significantly higher rates of PRAPARE social determinants of health risk significance at the 0.05 level, including stress, challenges accessing care, food insecurity, lack of housing, and worry about losing housing, as well as phone needs. We also found some marginally significant differences in several other domains, including utility needs, transportation, safety needs, and legal aid needs as well. So we also conducted multivariate linear regression models to determine whether the social determinants of health factors have effects on the likelihood of having uncontrolled versus controlled diabetes. And so after cleaning this data set, our sample included about 528 controlled versus 116 uncontrolled diabetics for a total of about 644 patients included in the final model. Our response variable was the status of diabetes, whether it was controlled or uncontrolled, and the possible explanatory variables were age, gender, language spoken, as well as the PRAPARE social determinants of health variables. So here we conducted model selection to achieve a model with the smallest NACHC information criteria in the AIC that estimates the relative quality of a model relative to other models for a given data set. This AIC model selection criteria basically selects variables for inclusion in the final model. And so the resulting final model included age, affordability of medicine and care, and the social determinants of health total score. So using this method, some of the interesting findings we found so far are that when we compared patients who did not have trouble affording medicine or care, patients who did have trouble affording medicine or care were 115% more likely to be an uncontrolled diabetic, and that was significant at the 0.05 level. We're looking into other analyses to better understand these relationships further. I also wanted to share in some other preliminary analysis comparing this time patients with controlled versus uncontrolled hypertension. We've also found that compared to patients who are not stressed, patients who were stressed were 53% more likely to have uncontrolled hypertension. And again, this was significant at the 0.05 level. So overall in our analyses, we're finding a consistent trend of the impact of social determinants of health across different chronic conditions, and we're really interested in exploring this further with other conditions in future analyses. So in conclusion, within our set of studies that we found that high-risk populations experience greater social determinants of health risks than general populations, and uncontrolled diabetics experience greater social determinants risks than controlled diabetics. And social determinants we found that they're related to clinical outcomes, including diabetes and hypertension that I mentioned. In particular, patient affordability of medicine really affects the likelihood of having diabetes control, and stress levels affect the likelihood of having hypertension control. In the future, we plan to also look at continuous measures of diabetes and hypertension, for example, using multivariate linear regression models to determine whether social determinant of health factors have effects on continuous values for hemoglobin A1C for diabetic patients, and systolic blood pressure and diastolic blood pressure levels for patients with hypertension. And we also plan to conduct these analyses with other conditions as well, and are especially interested in looking at those with multiple chronic conditions, including behavioral health conditions as well. So I wanted to talk a little bit about the limitations. Our study may be limited by the exclusion of intervention or enabling services data that address patient social determinants of health and provide context to ensure that we're not underestimating the social determinants of health risks of patients, given that a lot of these health centers very likely already provide needed interventions such as housing services, for example, that mitigate their patients' social risks of not having a place to live, or language services, for example. Just to give an example, we found in some previous studies examining social determinants of health without accounting for existing interventions already provided, very commonly provided at health centers across the country, had mixed results about the impact of social determinants for high-risk patients, and we're finding some of that as well. So I wanted to let me show you the next slide. I wanted to provide this slide to better illustrate the importance of social determinants of health intervention data. We believe that data on patient social determinants of health risk from PRAPARE plus data on interventions or response, such as enabling services, are both part of the value equation. That is, you really need to track both standardized social determinants of health data in combination with standardized intervention or enabling services data to demonstrate the value to payers by providing evidence of intervention services that improve preventive care and thereby reduce emergency department visits. Essentially, this data provides evidence about how these services effectively meet needs of complex patients and reduce total cost of care to achieve an integrated value-driven delivery system. Both data sets are also critical to be able to advocate for upstream investments that better target and improve needed interventions, that is, clinical care, enabling services, and community partnerships to drive care transformation and improve patient and community health. These data are also essential to be able to understand the volume of services, to be able to calculate a cost of care for adequate financing and sustainability. And so with this kind of information in hand, you really have more leverage to align payment with population health goals and ensure the financing necessary to sustain population health interventions, as well as to advocate for change at the community, state, and national levels. The bottom line is that both sets of these data really propel us towards transformed integrated care and really demonstrating the value. And with the findings of these kinds of PRAPARE findings that we've presented today, we're in a better position of explaining the impact of our interventions and demonstrating this value. And so in future studies, we plan to incorporate enabling services data to better understand this magnitude of the link between social determinants of health and appropriate clinical care, as well as the magnitude of the link between social determinants and health outcomes, as illustrated in this slide. Measuring the strength of these associations is really needed to evaluate this contribution of enabling services and other non-clinical interventions. And so I wanted to share with you at AAPCHO and working with NAC, we've already developed a protocol to document enabling services, and I wanted to share it with you in case you've not seen the data collection resources available on our website as well at enablingservices.apcho.org, including a data collection handbook, protocol, and implementation packet. All of these are also available in the PRAPARE Toolkit in Chapter 10 on the PRAPARE website, as Michelle had shared with you earlier. And so similar to PRAPARE, we developed these resources in partnership with a variety of community and clinic stakeholders and national partners, and you can see the example of enabling services categories there. And so overall, PRAPARE can help you better understand and manage high-risk populations and contribute to health equity by addressing patients' greatest needs and lowering total cost of care for the health system. In terms of our next steps, we're going to continue to support spread of PRAPARE to more organizations and patient populations through our programs such as the Train the Trainer Academy and Innovation and Engagement Awards. As Michelle had mentioned, PRAPARE is available for free in 6 EHR platforms and growing, and translated into over 5 languages. So it is the most dominant social determinants of health center tool used by nearly 1,000 health centers nationally. And so with these efforts of spread, we should have a lot more data available and plan to conduct additional research and analysis on the impact of social determinants on the outcomes and costs. And I wanted to mention with our partners at the University of Chicago, we were recently awarded a grant where we'll be exploring effective methods for scoring the PRAPARE social determinants factors for use in correlational analyses, including risk stratification, and looking more closely at our data to further examine the distribution of social determinants of health factors for controlled versus uncontrolled diabetic and hypertensive patients. As mentioned earlier, we also have a huge interest in better linking PRAPARE and enabling services interventions data in EHRs to better document the impact of non-clinical services and social determinant interventions. So here are the resources that are available now. As mentioned by Michelle earlier, we have the PRAPARE tool available on the website. We also have a very comprehensive implementation and action toolkit that includes the templates that we mentioned, lots of different resources, including 10 chapters on various topics needed for implementation and taking action on the PRAPARE domains, including building partnerships, information about interventions and enabling services, as well as readiness assessments or tools and timelines that you'll need to be able to get started on implementation and action of the PRAPARE domains and assessments. Also included on the website are webinars that are on the topics of give an overall overview of PRAPARE, as well as lots of different webinars, EHR-specific webinars and workflow-specific webinars, and frequently asked questions as well. So lots of different resources available if you just log on and take a look at that website that's shown there, nac.org/prepare. And any questions, you can contact Michelle Jester. And so I just wanted to acknowledge we couldn't have done all of this work if it wasn't for all the work and contributions of the PRAPARE implementation teams and health centers that we've worked with throughout the years. And really special thanks to Dave Faldmo and Aaron Hoffling and working with us on the patient data analyses. And last but certainly not least, incredible thanks to Vivian Lee, AAPCHO's research analyst, working on all of these analyses. Great. All right, and so our contact information is listed there in case there are any questions, and I believe we have a lot of time now for questions.
Great. Thank you so much, Rosie. So we've had several questions come in. There were a couple people that missed how we defined high-risk populations and then also what we categorized as uncontrolled diabetes and hypertension.
Sure. So how we did that was, so to answer the first question about high risk versus the general population, so we included 17 health centers that we worked with that had complete social determinants of health tally or domain data. And so the high risk was categorized as those with, maybe I should go back to the slide real quick. The high-risk populations were based on populations of focus that the health centers implemented at PRAPARE, denoting that these patients had multiple comorbidities. They were patients seeing a chronic care management team, for example, or patients with HIV or mental health diagnoses. So really specific populations of focus that were, focused on chronic conditions and other high-risk attributes, whereas the general population, these were health centers that said that they were implementing PRAPARE with their general adult population, for example, without any distinction of particular populations of focus. I hope that answers that question. And then for the, let's see, I think it was how we categorized uncontrolled versus controlled diabetics. We basically use the UDS definitions. We worked with Siouxland Health Center, and so they use the UDS definitions seen here, the hemoglobin A1C less than 9 as well as equal or greater than 9 for uncontrolled diabetics.
Great, thanks, Rosie. We've had a lot of questions around the PRAPARE score. I think it would be good, Rosie, maybe if you talked about how we did the tallies, because some people are asking whether we weighted the scores or if there's a scoring guideline. So maybe talk a little bit about what we mean by the PRAPARE score and tally.
Sure. So this social determinants of health total score, we've called it the risk tally score before. It really represents the cumulative number of distinct risks that are present versus absent for an individual patient. So again, it's this total score is calculated by summing the total number of present social determinants of health risk responses, as determined by literature, for individual patients completing the full PRAPARE assessment. So for example, again, for the domain of housing, the risk presence would be defined as not having housing, whereas absence of risk would be defined as having housing. So what we did was, and we have the methodology for this I'm happy to share. Actually, it's in the PRAPARE Toolkit. So for each domain, we went through and determined whether that category would be considered a tally of 1 or not. So I was thinking of preparing this slide for you all, as I thought it'd be a question, and I'm happy to send out a document that shows which tallies are considered risks or not. So again, for example, Hispanic Latino, a yes response for a patient being Hispanic Latino would be considered that maximum of 1 tally. We didn't do any weights, so we simply went through the categories of responses and based on the literature determined whether those would be considered as risks or not. So again, for example, language proficiency, language other than English would give a tally of 1, whereas speaking English would be a tally of 0. And we have specifications for maximum tallies. So for example, for some of these, we have more than 1 category that would be considered a tally of 1. So for education, less than high school degree and high school diploma would both be a tally risk of 1, whereas more than high school is not a tally of 1. Similar with unemployed and seeking work, under the employment question would be a tally of 1. Part-time work would be a tally of 1, whereas full-time work would not be included as a tally of 1. So I hope that makes sense, and I'm happy to share with you what we included as what we considered as risk responses for each of the domains versus not. So I hope that addresses that question.
Great. Thanks, Rosie. Rosie, would you mind maybe explaining a little more about why we didn't weight social determinants for this as of yet?
Yeah, I think, we really wanted to start with a more general, start with a more general scoring method. We didn't feel like we had we need to do some more data analyses to be able to better understand how to weight those. And so in our initial analyses, we really wanted to just start with something more simple and then look at how these analyses can contribute to weight. So after doing these, we'll get a better sense of, how we can weight some of these. And as I mentioned in the study that we'll be doing with the University of Chicago and Siouxland and other partners, we're going to be looking at these further, looking at how sort of effective methods for scoring these PRAPARE social determinants of health factors. We'll also be looking at, within those studies, risk stratification, looking further to examine, how the distribution of social determinants of health factors kind of, are related to each other and go along, which ones tend to go along with each other, which ones tend to be more unique, et cetera. So we'll be able to, with that funded study, be able to have more information on how or not to be able to weight some of these domains and the categories within the domains.
Thanks, Rosie. And someone just asked, Rosie, do you remember, is it Chapter 6 or Chapter 7 in the PRAPARE Toolkit where we have the data documentation and reporting tables? I believe it's Chapter 7. I could be wrong.
Look that up. It's one of those data evaluation chapters.
Yeah.
Slides. We can, I think.
Double check, yeah. So
yeah,
to the individual that asked where the guides on doing the scores are, it's either Chapter 6 or Chapter 7 in the PRAPARE Implementation and Action Toolkit, but you can find on our website.
Yeah, I have actually have a simpler one that I developed that we could, that is available as well. Because that one is in an Excel file. It's an Excel file that kind of shares with you it's meant to share with health centers a way to be able to do that on your own. So that's why it's the spreadsheet that is kind of the template, a reporting template for you to be able to use with your own data. So it has some automatic populations and things like that. So it's the one that's on the toolkit is a tool that you could use to be able to use that with your own data. I also have, a document that more simplifies that if we can share as well. So, but you can also see it in the toolkit. So.
Great. Thanks, Rosie. There's a technical question in regards to the model, Rosie. So someone asked, if you force age and gender into the model first, do the social determinant of health factors add significantly to the R-squared value?
Okay. Let me write that down. Is Vivian on the line?
Hi, yeah, I'm on the line. Can you hear me?
Yeah.
So R-squared is used to measure, is a measurement for linear regression, and in this case, we didn't use linear regression. We used logistic regression. But the A1C variable selection criteria we use is similar to R-square in a linear regression sense, in the case that it's selecting the best set of variables to be in the model. So initially, we had age and gender in the model, and all the social determinant health variables in the model altogether. But the A1C selection criteria selected age and affordability of medicine to be in the final model. So, which means all the other variables, in a statistical sense, they don't add to the explanation of the variation in the data. I hope that makes sense.
Great, thanks, Vivian. And this is in regards to someone who made a comment about the fact that eClinicalWorks, so the eClinicalWorks template, there is a smart form and then also a configuration guide so that you can build it, but you are correct in that the smart form does have this scoring system that for, if you have a risk, it's a score of 1 and so on. But the other EHR templates currently do not have this, again, because we wanted to be able to come up with a more sophisticated scoring system that would have weights associated with the social determinants. But as Rosie mentioned, we wanted to start out with these analyses first before going into that. There was a question in regards to, so the question is there any data available that would quantify the impact of social determinants of health on hypertension and diabetes relative to the impact of other risk factors? So, for example, could we answer whether social determinant factors are more or less impactful than genetic factors?
Vivian, do you want to take that one?
Sure. When I did the analysis, I actually did some literature search. There's not a lot of research have been done on comprehensive social determinant health factors. There are some research on, other comorbidities, other health risk factors, but not altogether with social determinant health factors. That is why our research, this pilot is very valuable, and we want to look into, in the future, if we have the chance to get more data, we want to be able to do that.
Great. And then there was also a question in regards to the spike that's found around 15 social determinants of health for the high-risk group. Do you guys have hypotheses as to what's going on?
Yeah, I looked into that. I'm not sure why the high-risk group, after dropping from 10, 11, 12, 13 is all a downward trend, and then 14 and 15, it just went up. I'm not sure why, but my hypothesis is because on the higher risk scores, there are very few people. So a slight jump in number will cause the percentage to jump a lot.
Great. There was a question around if there's been any attempt to disaggregate the data concerning Asians and Native Hawaiians and Pacific Islanders.
Certainly.
And asking if you could clarify how Native Hawaiian and Pacific Islander populations were assessed.
Yeah, certainly. Yeah, we're AAPCHO, we're Association of Asian Pacific Community Health Organizations, and in case the audience wasn't aware, we're an association or a network of health centers serving Asian American, Native Hawaiian, and Pacific Islander patients across the country. So we are total in agreement with disaggregating the AN and Hopi populations further, and we provide this. We provided this in our data reporting template for health centers, and we encourage them to report all the different subpopulations, for example, and we just we couldn't force it, but we took what we took what the health centers could provide for us, and so there was separate categorizations for Native Hawaiians, Pacific Islanders, and even some subpopulations under those, as well as for Asian Americans as well. So we want to encourage folks to be able to use those templates that disaggregate those populations further. And at AAPCHO, we have a very keen interest in wanting to look at those further. But for this, these data sets, we use the data that was available from the health centers. I hope that answers that question. And if anyone is interested in that, please let us know. That's definitely something that, if you have the disaggregated subpopulation data and are interested in looking at that further with us, we'd be really interested in that, and, along with our health centers. So great question.
There was a question around geographic variation, funnily enough. So Roseanne or Vivian, do you want to talk about the differences that you did find across the states? We didn't present this because we didn't think we would have time to go through all of those, but AAPCHO has done those analyses.
Yeah. Do you have those in front of you, Vivian? Let's see. Yeah, so we did look at you know, what the national aggregated data set looks like. So just in general, not necessarily looking at, you know, different types of populations of focus like we did here. And so, you know, some of those were really interesting findings as well. We wanted to focus here on the high risk versus the general populations for the purpose of this this webinar, but we'll be sharing some of those more general findings in a you know, in a future in future dissemination. But do you want to share some of the high level findings of that, Vivian, if you have those in front of you, or?
Sure. There are some differences that we saw, especially in the tiling score. Some regions had higher tiling score than the others. But one thing to note is that the population of focus of the health centers might be different. So that might be what's causing the differences in the tallies. And for the individual social determinant of health, by region, some places had different, you know, some had higher uninsured rate, or some had lower, less than high school education rate. But again, that could also be caused by the difference in the population of focus from the health centers.
Right, right. So another, you know, like in California, we did find patients, you know, compared to the other states, you know, those with more language barriers, for example, you know, some things like that that might just be regional or state differences. But again, like Ian said, it could potentially be the, you know, populations of focus as well. So once we have, you know, been able to gather more data on general populations, we'll be able to better assess some of these as well.
Thank you, guys. Sorry to put that on you. There have been a couple questions on, like, people acknowledge that PRAPARE is widely used across health centers, but if it's really being used by other organizations. And yeah, we're finding that a lot more hospitals are starting to use PRAPARE. We've also been approached by several Medicaid agencies interested in using PRAPARE. And there was a question on whether community-based organizations could use PRAPARE if they don't have a EHR. You're more than welcome to use the paper tool, so that is also available on our website. Feel free to check that out. And then from there, you can either use the paper tool as is, or if you have a different data system. We would ask that you work with me at NAC, so Michelle Jester at NAC, if you're developing it into a different software system just for like intellectual property and licensing purposes. But definitely happy to work with you guys to do that. And then there was another question around if PRAPARE data, are there any efforts underway to partner with payers to incorporate social terms of health PRAPARE data as well? So yep, I think there's a lot more interest from various different types of payers. There's several managed care organizations that are interested in collecting social terms of health data. We have been in contact with some of them. We've been in contact with several health plans that have expressed interest as well, and then again, Medicaid agencies. So that's, and I think also the state primary care association, so we partner with them a lot on the building and the testing and using the data, and they've done a lot of work on using PRAPARE data to inform conversations with state policymakers as well, to inform those either alternative payment methodologies or incorporating them into some delivery system transformation efforts that are happening at the state, whether it's like a 2703 Health Home initiative that's happening in the state, or a state innovation model, or whatnot. So we're finding that it's being used in lots of different ways for lots of different levels of change. So there was a question around the fact that PRAPARE, might be long for some organizations, and so the question was around our thoughts on taking subsets of the questions to administer and how would that affect effectiveness. Rosie, did you want to talk about that?
Sure. We developed maybe we should talk, Michelle, about some of our development process, and we took a lot of these into account, with our stakeholders, wanting to develop something that would be, really effective, yet not too long, not too infeasible for use at, their health organizations. And so we went through this, a couple years in developing it and working with our stakeholders and piloting it to really come out with these core PRAPARE questions. And then we also had a set of optional questions because, folks were interested in doing more, but, again, we didn't want to make it infeasible for health centers to be able to implement this. And so we want to be able to stress using the full PRAPARE tool so that we can compare, apples to apples across health centers and other providers nationally. And so the more or less, the less that you're able to, collect using the full PRAPARE tool, the less effective that'll be for national or state advocacy or, advocacy with others. And so we really wanted to be able to create a standard so that we can talk, on this aggregated and talk on a, a critical mass level to be able to affect change, policy-wise, nationally, state-wise, community-wise, et cetera. So, it's really important. We feel it's really important to be able to use the full core PRAPARE tool to be able to be effective in all of these efforts. Hello?
Oh, sorry. Thanks, Rosie. Sorry, I was on mute. And I would just like to add that if you're using one of the PRAPARE electronic health record templates, a lot of the information that you see at the beginning where it's like race, ethnicity, and other demographic type of questions, those are automatically populated into the PRAPARE EHR form. So if you're collecting that as part of registration or check-in, and the front desk is filling that out, then it would automatically populate into the PRAPARE form, so you don't have to ask those questions again. So hopefully that cuts down on the number of, like, quote-unquote new questions that you would potentially be asking.
Good reminder, yeah.
Great. Great. Rosie, got a question around validation of PRAPARE. Do you want to talk about that?
Yeah, we're, I guess it would be good to know the validation in what sense. But in terms of the analyses, we're really getting a look at some of these preliminary data sets coming in, and we're taking a look at it, and we're kind of going through that process right now. Again, some of the analyses that I mentioned will help with the validation. Looking at in our future studies, looking at the distribution of scores and validating it against, health outcomes to be able to look at, how effective these social determinants of health domains are. So we are, in that initial process of looking at this data to be able to better understand that.
Great. Rosie, there was another question again. Let me try to find it. Essentially around, are there ways to collect standardized data on enabling services and coding and whatnot? So do you maybe mind repeating kind of y'all's work and the work we hope to do in the future?
Sure. Let's see. Are there ways to collect standardized intervention data? So let me move to the slide here. I kind of went through pretty fast. Oops. Oh, you're doing that. Okay, great. moving by itself. Just to give an introduction to AAPCHO's enabling services, we developed this in collaboration with the New York Academy of Medicine, Heidi Park Emerson, which we miss very dearly working with her. We basically started this project because our health centers were coming to us and realizing that there's so many services that the health centers are providing that aren't tracked and they aren't being recognized for all of these essential services that they're providing to be able to improve patient access to care and get them to come in for prevention visits and thereby reducing the emergency department visits and helping to reduce the total cost of care. So we together with them and other stakeholders and with NAC and others, we developed this data collection system, and it's available again on Chapter 10 of the PRAPARE Toolkit, as well as at enablingservices.apcho.org. So we have a whole data collection implementation packet that includes this handbook that you see there that goes through the whole data collection process, what the definitions and examples of what's included in these definitions, and examples of services that are not included in these codes. And so you can see the codes there. We also this was meant to develop something that we could use for cost reimbursement purposes, to be able to communicate with health plans how long these services are taking, so we have minutes, for example, that are tracked within this data collection system. We also have who is providing the service, so that we can understand the costs associated with different types of providers. We also have whether we also track whether the language, the service was provided in a language other than English. So all of these, what we track and don't track, is included in the resources on the website, and so what we want to the resulting data that would come out of the implementation process. We want to be able to use that to be able to share with health plans and communicate the volume and all the extra efforts and services that are provided to health center patients in this particular case, but can be used with other types of providers, to be able to address a lot of these social determinants of health and how they improve health outcomes and how they contribute to appropriate care. So let's see, the framework that I shared earlier, how these enabling services really mitigate appropriate care and better health outcomes, and how they reduce health disparities for our populations. And so you can find more information on the website about the particular categories. And we really, again, wanted to be able to develop a national standardized system to be able to create, with, again, like PRAPARE, create a critical mass of standardized data to be able to be effective in our efforts. I hope that answers the question.
Great. Yeah, and I think we'll end it there just due to time. Thank you again so much to Rosie Chang-Weir and Vivian Lee of AAPCHO for doing all this amazing work and for being willing to present. And thank you all for joining us. Again, here are our emails if you'd like to get in touch with us. And otherwise, we will be posting the slides and the recording on MyNAC later. So thank you all.
Great. Thank you, everyone. It's been a pleasure.